Good to go.
Okay. Good evening, everyone, and thank you for joining us. My name is Nora Gashi. I'm the president of the Albanian American Medical Society. I wanted to personally say that it's great to see so many Albanian medical professionals at different stages of their training participating in these events. As we continue to grow our society, we will be having more events like this. We encourage all of you to join our society and also share with us any topics that you would like to be featured in future seminars. As members, you would also be able to lead a featured seminar. With March being a Colorectal Cancer Awareness Month, we at AAMS wanted to do our part in spreading information about colon cancer. Tonight, we have Dr. Malellari discuss methods of prevention and treatment of colorectal cancer. Dr. Lorenc Malellari is a board-certified colorectal surgeon currently practicing in California. He serves as the medical director of the SA Camp Company's Robotic Surgical Center and as the educational director of the Albanian American Medical Society. I'd like to thank Dr. Malellari for his time and effort in putting this presentation together, and thank you all for your participation. After the presentation, we will have questions and answer session. We will be happy to take your questions. I will now turn it over to Dr. Malellari. Lawrence.
Hi, Nora, and hello, everyone. I'm just going to take a second here to switch our screens. There we go. Well, first of all, thank you everyone for taking the time tonight to join us to discuss a topic that's actually quite important and fairly neglected, I would say, in most physicians' offices and even most homes and discussions. But colorectal cancer is actually very common cancer that most people don't realize how much it affects our society, especially here in the United States. And hopefully by the end of this conversation and presentation, you'll have a better understanding of colorectal cancer in general, and also some of the prevention methods, screening methods, and also treatment options as well. So March, as Dr. Gashi mentioned, is a Colorectal Cancer Awareness Month. So why are we wasting a whole month to raise awareness on a particular cancer, right? We have Breast Cancer Month, we have Heart Month. Why do we have a Colorectal Cancer Month? Just a quick overview of what we're going to go over today. I won't bore you with the details, but you'll see it over the next hour. And at the end, I'll have some, I'm a surgeon myself, so I'll have some videos of the surgery if you're interested in seeing them, and obviously if we have time as well. So what is colorectal cancer? First of all, just as the name says, it's a growth or an abnormality that occurs in the lumen of the colon and the rectum. Usually will start as a growth, which we call polyp, and over time, mutations in the polyp will turn cancerous, which can grow through the wall of the bowel itself and occasionally go to other organs as well, causing metastatic disease. And this is how we stage colorectal cancer, kind of briefly with a little anecdotal pictures here. But the growth in the lumen of the colon, as you can see, always starts on the inside. As the growth reaches a certain mutation level, you will achieve the ability to grow through the wall of the bowel itself. And that is when stage 2 cancer becomes present. Once the lymph nodes become involved, as you can see over here on the side, that gives a diagnosis of stage 3 cancer. And when those tumor cells reach other organs of the body, it becomes stage 4. So why should you care? Again, why are we spending so much time with this? Well, the colorectal cancer is actually the third most commonly diagnosed cancer in the United States. It's the second leading cause of cancer-related deaths in the United States. More people die from colon cancer than die from breast cancer. More people die from colon cancer than die from prostate cancer. The only cancer that kills more people is actually lung cancer. And when I say this, a lot of people are surprised to hear that. It affects both men and women, all racial and ethnic groups. And if you want to get a number as far as what is your lifetime risk of developing the cancer, about 1 in 23 men and about 1 in 25 women will develop colorectal cancer during their lifetime. So it's about a 4.5 to 5% lifetime risk. Unfortunately, this cancer has very minimal and very non-specific symptoms, which is why it's missed a lot, especially early on. And it's a very life-changing diagnosis. Cancer, just the word cancer alone is a life-changing diagnosis. But as we go through some of the treatment options, you'll see that it really is a life-changing diagnosis. Now, if you look at the whole world, the incidence of colorectal cancer, you can see the countries who are darker in color are the ones that have higher incidence of colorectal cancer. And you can see it's affecting mostly more of the developed countries rather than, the African or Southeast countries and Southeast Asian countries. Now, if you look at the mortality rate, that follows the same as well, meaning that the same countries that have higher risk of cancer is also having higher risk of or higher rates of mortality for this cancer as well. If we're focusing on the United States, just to give you guys some numbers about colorectal cancer, in 2020, an estimated 148,000 people were diagnosed with colorectal cancer. About 53,000 of them were passed away from this diagnosis. But we're better at taking care of this disease. So about 1.3 million people still live with this disease in the United States nowadays. Yet it is a highly preventable and treatable disease because we know exactly where it occurs. We know exactly how to find it. The main problem that we have is getting people screened adequately at the appropriate time so we can catch this before it becomes advanced or metastatic. If everybody that was supposed to get screened at the appropriate age was screened in the United States, about 40,000 lives could be saved. And that's a pretty significant number. This graph is to give you guys an idea of how things have changed over the past few decades. So this is looking at from 1990s to 2018 approximately. The lighter color shows the incidence, while the darker color below is showing the death rate or mortality rates. As you can see, the numbers are improving, but there's a lot of work left to do on this problem. And here you can see the spread of colorectal cancer diagnosis among age groups on the right side over there. You can see that as the age becomes over 50 and 60 years old, those numbers increase. And on the left, you can see the separation between male and females and different racial groups and ethnic groups as far as incidence of developing or diagnosing colorectal cancer. If you put all these numbers together, though, and you want to get a median age of diagnosis for colorectal cancer is 67. Now, looking at mortality, you can see that the graph on the right kind of shifted a little bit more to the right, while the ones on the left, you can see it's still showing a similar pattern where certain racial groups have a higher incidence of colorectal cancer, but it's somewhat similar to between men and women. The median age of mortality or death for colorectal cancer is 72. Now, if you look at survival, meaning if we're diagnosing a patient with this diagnosis of cancer on the colon or rectum, what are our expectations for their 5-year survival? Now, localized disease means when the cancer is still within the lumen of the colon or the wall of the colon. So you're looking at stage 1 or stage 2 disease. 5-year survival is really good, more than 90%. Once the tumor, however, leaves the area of the colon where it started, meaning it reaches the lymph nodes, you can see that the 5-year survival rate drops. So it goes down to the 70s or so. Once tumor has reached other organs and becomes metastatic, the survival drops precipitously down to the teens. 14% is the current rate. And the unknown is when we don't know the stage of the diagnosis of those particular patients. Now, if you take all patients that get diagnosed with colorectal cancer and you just say, it doesn't matter what stage they are, how many of them are still alive at 5 years after diagnosis, that 5-year survival comes down to 64.6%. So it's not that great. But if you look at what's been going on, at least in the United States, on survival over the past several decades, and this graph is going all the way back to 1975, you can see that back then survival was less than 50%. So that number has improved, but there's still a lot of work left. And this is another graph showing the trends. This is all diagnosis of colorectal cancers, incidence between 2000 and 2018, and below is the mortality in the United States. And you can see that both graphs show a significant, or at least a reasonable drop as the time passes on. But we've noticed something significant recently. For the past few decades, we've noticed that patients who are less than 50 years old, the incidence of diagnosis in that group of patients is actually going up. The mortality has not significantly changed yet, but we can see that this is starting to trend up as well. And that's a problem, because up until recently, the screening guidelines recommended a colonoscopy to be performed in patients who are 50 years old or older, at least the ones who are average risk for colorectal cancer. This is a group of patients that we're actually missing. They were actually not being screened for colorectal cancer, and we are diagnosing more of them as time passes. And there's been some recent publications that support these numbers and this graph. This is one of the more recent ones. This was back in 2017 when it was published, and you can see that colorectal cancers in patients who were over 50, the incidence is going down, both for colon and rectal below. But when you look at patients who are less than 50 years old, the incidence is going up, both for colon cancer and rectal cancer. So the Never Too Young campaign started with the Colorectal Cancer Alliance to raise awareness and make this fact, kind of make physicians, I should say, aware of this fact. And there's been articles published in major newspapers about this particular, finding as well. And more recently, we've had, some celebrities that have been involved with this as well. More importantly, Chadwick Boseman, who was the Black Panther actor, passed away at 43 last year. And he was stage 3 colon cancer when he was initially diagnosed. Will Smith had his colonoscopy in November 2019 because he was 50, and they found precancerous polyps in him too. If you want to feel old, Will Smith is 50 years old. So the Never Too Young campaign was set up to raise awareness of this fact. And just to give you guys a perspective of what numbers are we really looking at, back in the 1990s, only about 6% of colorectal cancer diagnoses were made in patients who were less than 50 years old. In 2020, 12% of those diagnoses were made in this group. That's about 18,000 people who were diagnosed with colorectal cancer who were less than 50 years old. The other significant fact that goes with this is that a lot of these diagnoses are being made in patients who are in their 40s, but also they are being diagnosed at much more advanced stages, meaning that a significantly higher percentage of patients who are less than 50 years old are being diagnosed with stage 3 or 4 cancer rather than stage 1 or stage 2 cancer. And if you remember when I showed you the picture about 5-year survival, the more advanced the cancer is, the lower the 5-year survival rate is going to be. And our goal as physicians is to try and hopefully prevent the cancer, but if we cannot prevent it, how do we diagnose it as early as possible so we can give those patients the best survival advantage we can? So the CRC stands for colorectal cancer. The trends in patients who are less than 50, you can see both males and females, those trends are going up. And even by year of diagnosis, you can see the numbers on the right over there. So if you kind of split those numbers by ethnicity and racial group, you can see that actually the majority of the growth in this age group is happening because of whites who are less than 50 years old rather than minorities. Even though African Americans have a higher incidence of colorectal cancer from the beginning anyway. So why is this happening? Let's kind of get a sense of what's going on with the United States and these age groups. And if you're looking at just white Americans who are between the ages of 20 to 50 years old, this is looking at the incidence of colorectal cancer between 2001 and 2005. So 5-year, kind of a timestamp. The bluer colors have low incidence. The kind of a yellow orange colors have a higher incidence of colorectal cancers. Now, if we move by a 5-year mark, you can see here, look at the incidence of colorectal cancers, what's going on. So while it started in the Southeast United States, it's kind of spreading through the rest of the United States, all right? Now, if you look at mortality, it's showing a similar pattern as well. Higher mortality rates in the Southeast United States. This is back in 1996, actually 2000. So let's move at a 5-year, kind of gap in between. Look at what's happening. Huge increase involving basically most of the United States, right? The increase is so significant that the overall country's rate has gone up as well. We know that colorectal cancer is affected by numerous factors. Obesity is one of them, so which means BMI more than 30. Now, this graph is showing you, or this map, I should say, is showing you the obesity rates by state. Obviously, it's not much more granular as far as counties and cities, but by state, you can see that the darker areas have a higher BMI and the lighter areas have a lower BMI. It kind of fitting with that pattern that we saw on the incidence and mortality rates of colorectal cancers. And you can see that the obesity rates have been going up from the 1960s, and it's affecting both men and women in this age group. If you look at vegetable consumption, and we know that dietary changes do have a significant impact on developing polyps or your risk of developing polyps and colorectal cancer. And you can see that the darker areas who have lower consumptions of fruits per day are kind of congregated in the same area that we saw colorectal cancer rates being higher. Same thing with vegetables and physical activity. This one is showing, by physical activity here, you're looking at basically how active are patients in this age group by state. Again, it's not too granular here, but it gives you an idea of anyone 18 or older. The darker areas have lower activity levels than the lighter areas. And this is leisure activity, not work-related activity. So again, it kind of gives you an idea of why are we seeing some of the higher incidence of colorectal cancers and mortality rates kind of focused on that particular region of the United States. So who can get this disease? Well, hopefully it was clear already, but everyone can get this disease. There are certain risk factors that we know that are associated with colorectal cancers that you yourself can control, and you can help your patients control as well. And physical inactivity was one of them, as you saw on the map over there. Obesity rates, smoking, heavy alcohol use, and dietary factors, mainly fiber intake. But there's some factors that you cannot control, no matter who you are or what you do, and that's age. We're all getting older. As you get older, your risk of colorectal cancer does increase. As you remember where I showed you the graph with incidence of colorectal cancers, in different age group, the older you were, the higher the incidence of colorectal cancer was. Family history, you can, pick your family, which means that if you have family members that have a diagnosis of colorectal cancer, your risk of colorectal cancer goes up as well. Obviously, you can control your genetics and certain medical problems like inflammatory bowel disease, namely Crohn's disease or ulcerative colitis, has been shown to increase risk of colorectal cancer, and uncontrolled type 2 diabetes as well. And as I mentioned a little bit earlier, some specific racial and ethnic groups do have a higher incidence of colorectal cancer. So how do you deal with this? Try and again, control the risk factors that you can control, but get screened. That is the key. It is a silent disease, unfortunately. It is not, unlike breast cancer, you can't feel your colon. There's no external exam that you can do to get a diagnosis of colorectal cancers. But we know that there are certain symptoms who are associated with colorectal cancer, and patients who have been diagnosed with it have been reporting. And some of the symptoms include things like blood with bowel movements, both in or around the stool, changes in their bowel habits, both diarrhea and constipation have been associated with it. Changes in the caliber of the stool, meaning they're having narrower stools or kind of a disconnected stooling, sometimes cramping or abdominal pain, weakness, fatigue, weight loss, which is not on purpose, meaning unintended weight loss, have been associated with colorectal cancer as well. As you can see, the symptoms are so generic. There's not a million other things that patients would have with this same symptoms as well. And that's one of the reasons why such a difficult diagnosis to make by just examining the patient or getting symptoms from them. The screening guidelines that we have at this point, and there's numerous societies, as you can see on the right over there, who have spent a lot of work and time to come up with this guidelines. But there's basically two groups that we separate our patients into. And one is the average risk, meaning everyone that does not have any history of or family history of colorectal cancers, no history of the other risk factors that can increase your diagnosis, and the group that has high risk factors. And that is if you had history of polyps in the past, or history of colorectal cancers in the family, history of inflammatory bowel disease, or genetic mutations or syndromes. The U.S. Preventive Services Task Force just came up with a new rule, which should be finalized this year, about recommending screening colonoscopies for anyone between the ages of 45 to 50. Anyone above 50 was already finalized. And the reason why I put this slide up here is because with this rule change, now Medicare will be reimbursing screening colonoscopies for patients who are 45 and older, even if they do not have any symptoms or any other factors. Prior to this, because reimbursement rates and coverage of this screening procedure or preventive procedures was limited to patients who are 50 and older. And again, because of all the data that we have now and the numbers that I showed earlier, this is being finalized as well, and should not be a problem for patients getting their screening test covered by insurance. So how are we doing with our screening rates and our screening test? Now the slide on the right over there, or the graph on the right, is showing screening rates by year. And as you can see over not a very long period of time, but between 2012 and 2016, no significant improvement in the in screening rates. Now, if you look at the actual screening rate by age group, you can see that some of the older patients have better screening rates, but the patients in their 50s, lower screening rates. And that's still pretty unfortunate that we cannot do better than this. And as I mentioned in the beginning of the slide, if we can get everyone that's supposed to get screened on time and appropriately, we can drop mortality rates of colorectal cancer in the United States by 40,000 people every year. That's a huge number. So who should get screened? What are the actual guidelines? What should we tell our patients, and who should we be screening? So all men and women aged 45 to 75, meaning that whether they have or symptoms or otherwise, they need to get screened between these age groups. Anyone above 75 should be individualized, and that has to do with the fact that usually patients who will be 75 or older will have numerous other medical problems, which can take priority and decrease their expected lifespan. Usually the recommendations are to stop screening after age 85, but I put a little asterisk on it because we all have seen patients who are 90 years old or older. They are healthier than some 60 years old. So be aware that as long as a patient has a colon and a rectum, they are at risk of developing colorectal cancer. So unless their life expectancy is less than 5 years, they should be screened for colorectal cancers. Higher risk patients, as I mentioned earlier, will need to get started a lot sooner. And that has to do with the fact that this age group will develop colorectal cancer at significantly younger ages. So screening them is important to prevent that from happening. African Americans, the screen age for African Americans have been 45, for many decades actually, and that has to do with the fact that, as I mentioned earlier a little bit, the African American racial group has a significantly higher incidence and mortality rate from colorectal cancer compared to the other groups. And same thing with Alaska Natives and American Indians. And again, now with the more recent identification of younger patients getting diagnosed with colorectal cancers. So again, start at 45 for colorectal cancer for average risk patients. And what are the screening tests that we have available? I'll go over this in a minute as well, but basically colonoscopy should be performed at least every 10 years when there's no findings at the colonoscopy. Fecal occult blood test should be done at least annually. FIT test, which is also a stool test, annually. FIT DNA test, was also known as Cologuard, should be done every 1 to 3 years. Now, the reason why it's 1 to 3 years is because Medicare only covers it every 3 years. So if a patient wants to get it done sooner, or you think that they should be getting it sooner, there will be an out-of-pocket expense, and unfortunately, it's not very affordable. Flexible sigmoidoscopy, CT colonography, which is also known as virtual colonoscopy, and double contrast enema, which are not really done anymore, are done much more frequently. High-risk patient, when do you start? Well, it depends on why they're high risk, right? So if they are high risk because a family member had diagnosis of colorectal cancer or polyps, then they need to be screened at least 10 years before the diagnosis was made in their family member. So if someone was diagnosed at 50, then someone in their family was diagnosed at 50, then they need to get started at 40. If someone was diagnosed at 45, they need to get started at 35, etc. Inflammatory bowel disease, ulcerative colitis, and Crohn's disease, especially uncontrolled UC or Crohn's. Patients who have uncontrolled ulcerative colitis have a 10-fold increase of developing colorectal cancer compared to the average population. So they're at significantly higher risk. And genetic mutation like FAP or HMPCC, also known as Lynch syndrome, those patients will routinely get screened for colorectal cancer in their teens and early 20s because their risk is so high to develop colorectal cancers. When do you do repeat screening? Well, as far as the colonoscopy is concerned, if you find polyps at the time of colonoscopy, depending on how many polyps you find and what type of pathology you get basically from those polyps will determine the repeat colonoscopy. Usually it's 3 to 5 years, as you may see over there. So just to kind of clarify a little bit about the type of test and just to kind of put things a little bit more, to clear them out basically a little bit, there's 3 types of tests. There's stool tests, there are endoscopic tests, and there's radiological tests. The stool tests include the fecal occult blood FIT test and Cologuard that I mentioned earlier. The endoscopic tests include the colonoscopy and the flexible sigmoidoscopy, and the radiological test is mainly the virtual colonoscopy. Double barium enema has not really been done anymore. Colonoscopy, though, is the gold standard for screening for colorectal cancer. And not only that, but colonoscopy is the only test with both a diagnostic tool and a therapeutic tool. And by that, I mean that colonoscopy is the only test that will not only diagnose a problem, whether it's a polyp or a cancer, but will also remove the polyp, meaning deal or treat the polyp, or at least biopsy the mass to confirm the diagnosis of cancer. And I put this article up here because this was the reason why Cologuard actually became part of the screen. And it got basically FDA approval and Medicare coverage for it. It's the scientific term for it is not Cologuard, it's actually multi-target DNA testing. So what the company is doing is testing for specific DNA strands in the stool of the patients to identify those who have polyps or cancer. And the way that works is that as stool is passing through the wall of the colon, it's rubbing through those polyps and masses and kind of sloughing off cells through it. And this test is basically looking to identify that test. And you can see in comparison to the FIT test, which is only looking for blood in the stool, there's significant improvement or increase, I should say, in sensitivity of the test. But that also means that there's a lot of false negatives as well, meaning that you'll have a positive Cologuard test, but actually a negative colonoscopy afterwards. And this is the same thing looking at the actual positive and negative results between the 2 tests. So colonoscopy, everyone dreads this, and every patient that I've ever spoken to about needing a colonoscopy kind of looks at me like, no, you didn't just say that. But this is basically what a colonoscopy is. Now you can see the colon involves the whole abdominal cavity. It starts on the right, goes across the belly, underneath the ribs over here, and then down on the left. Colonoscope or colonoscopy is basically a flexible camera with a light at the tip that the physician is going to maneuver, as you can see on the picture over here, from the kind of the back side of the patient as the patient is laying on the side, and slowly and carefully maneuver the scope through all the curves and the loops of the colon until the whole colon is visualized. And you can see numerous issues and problems with this, from polyps to masses to diverticulitis to ulcers to AV malformations, etc. So it's a really great tool. So what do polyps look like? Well, this is what some polyps look like. They have all kinds of shapes and colors and all kinds of abnormalities. But basically, you can see that it's an abnormal growth in the lumen of the colon. Sometimes it can be pedunculated or with a little stalk, as you can see over here. Sometimes it can be flat, like this one or that one. And here's a few other ones that you can kind of get a sense of what we're talking about. What do you do when you find a polyp? As I mentioned earlier, during a colonoscopy, you can actually not just diagnose it, but also treat it. And one of the ways that you can treat it is by removal using the snare, as you can see from the diagram over here. So snare is basically a loop of a wire that you can put through the colonoscope, wrap around the polyp, and excise it out. And the good thing about this is that then you retrieve the polyp, and then you send it to pathologists so they can identify and tell us whether there's any cancer cells in that polyp. And here's a picture of a real-life polypectomy. You can see the polyp over here is quite large. It's on a little stalk. You can put a snare around it. You transect it on the other side. You retrieve the polyp, and that little black mark on the side is usually a tattoo that we'll place at the area where the polyp was removed, so that if you need to go back, whether it's to remove the polyp or to see that, to remove the colon or to see whether the polyp grew back, you can find the area. And here's another picture of a polypectomy. So you can see a polyp over here. There's an instrument around with a snare, and this is what the snare looks like. It's basically a loop of a wire where we can basically allow for cautery to happen as well. So it gives you control of bleeding with it. All right, so going to our treatment part of the colon, and my favorite part, which is surgery. So surgery is like real estate. Location, location, location. Where the mass and where the cancer is will determine what you can or what you should be doing with it. And the goal of the surgery is obviously important to remove the cancer, but timing matters, right? So if the cancer is still localized to the wall of the colon, removing that section of the colon will treat the cancer. But if the cancer has spread to other parts of the body or other organs, it becomes advanced or metastatic, at which point surgery may become unnecessary or futile at that point. The treatments for colorectal cancer also include chemotherapy, and specifically for rectal cancer, radiation as well. So goals of the surgery, as I mentioned, the removal of the cancer, but another part of this is staging the cancer. And that has to do with the fact that figuring out whether the cancer is stage 1, stage 2, or stage 3 matters. Stage 1 or stage 2 cancers will usually be cured by surgery alone. Stage 3 cancers will require chemotherapy. And stage 3 cancers, you may not be able to identify them before surgery, because sometimes the lymph nodes will be enlarged, but sometimes they won't. Sometimes they'll have tumor cells in them, but they will look normal on a CT scan or other imaging modality. So the only way to confirm whether they are indeed stage 3 or they're not stage 3 is to have those lymph nodes evaluated by the pathologist. And the goal is, again, to increase cancer survival. And how do we do this in a way that is as minimally invasive as possible, so the patient can recover as quickly as possible from their surgery and move on with their life, or get on with their next treatment that they need. So again, like location, 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 right? So if the cancer is located here in the what's called a sigmoid colon, where the blue little dot is, that this part of the colon has to be removed. and then the other ends are put back together. If the cancer is in the middle over here, then that part of the colon has to be removed, and the other ends are put back together. And the important part about cancer is that you have to perform what's called an oncologic resection. So if you can see over here, if you have a cecal cancer or an ascending colon cancer, the whole right portion of the colon has to be removed. If you have a descending colon cancer, the whole splenic flexure and left colon has to be removed. And that has to do with the fact that we need to harvest or remove the lymph nodes that are associated with that side of the colon. So if you can see over here, this is the right side of the colon. These are the lymph nodes that we need to harvest and send to the pathologist so they can tell us whether those lymph nodes have tumor cells in them, because that will determine, again, whether the patient is stage 3 or not. Because the worst thing you can do for a patient is downstage them, meaning that you remove the cancer where it occurred and they recover great from the surgery and they do well, but you miss the fact that they needed chemotherapy afterwards because you didn't have enough nodes or you didn't remove the adequate lymph node basing, at which point they will not be treated, for example, with chemotherapy as they should have. So those patients will recur and they'll have cancer come back. And usually when cancer comes back, it comes back with a vengeance. So what are our surgical options? So we do have some advancement in surgery now, as I mentioned earlier, doing it in as minimally invasive fashion as possible. And here, just kind of giving you a bit of a timeline with surgery. This is open surgery. Just to kind of direct you guys, this is a female, that's a uterus over here, that's the colon and the rectum, and you can see the open abdomen. Then we had laparoscopic surgery. You can see the surgeon's shoulder is already hurting just by looking at this picture. And then we have robotic surgery, which is the latest advancement we have on minimally invasive surgery. So open resection will look like this. If you ever had a patient that had an open surgery, I'm sure you're very familiar with this picture. You know, this is the belly button right here. The head is up top. The feet are at the bottom. You can see these surgical staples that usually are placed in the middle. And it does take, a significant amount of time for that to heal. And the patient does have usually a lot of pain as they are recovering because it's a pretty large incision. In minimally invasive surgery, our patients will have incisions like this. And as you can see over here, there's small incisions on this particular patients where the robotic instruments were placed, or laparoscopic instruments, depending on how the procedure was done. And this incision, which is basically a C-section type incision, is where the colon comes out of the belly. And same thing over here. This particular patient is actually a patient of mine who had his whole colon taken out through this incision over here and this small incision right there. So this is a ileostomy that patient needed. Transanal resection is some of the latest stuff that we're working on, but this is what the robotic instruments are. As you can see, this is a dime, just to give you an idea of the size of the instruments that we have that we can use in the operating room. The patient will be sitting on the table over here. There's an assistant next to the robot that exchanges instruments and helps the surgeon. And the surgeon is usually sitting on the corner over here controlling the robot itself. And the robotic tips, I can see on the right over there, can actually rotate more than the wrist of a human being basically rotates. So you have extreme articulation inside of the abdomen that you would not have otherwise. So how are we doing with this MIS colon resection in the United States? There was this article back in 2015 that looked at the different regions of the United States and what was the percentage that they were getting. And if you look at the West Coast, because I'm on the West Coast over here, only about 57% of colorectal resection is actually done in MIS fashion. So still a lot of work to do on this one. And you can see rectal resection over here. About 60% was still being done in an open fashion. This is what the surgeon sees, by the way. So these are the controlling instruments that the surgeon has, puts his hands in basically, and you have stereoscopic vision because you have two separate cameras inside of the belly, and you can see, just like when you're watching 3D movies, for example, when you go to a movie theater, or when you have those AR cameras. And I have a video here of a right colon resection. And this was with an intracorporeal anastomosis. Now this video, just to give you guys an idea, is working at 2 times the speed, normal speed. So you can see the instrument moving a little fast. That's because it's, otherwise it will take a while to see the whole thing. And he's also obviously trimmed for time. There's the mass. And that blue dot that you saw over there was basically the tattoo that the gastroenterologist put on for marking. Some anatomical identification, namely the urocholic bundle. If you remember the picture I showed you where the lymph nodes are, where the lymph nodes follow that vessel. And that black node right there, it got colored because of the tattoo that the gastroenterologist placed. So for, luckily for that particular patient, you could actually see the lymph node that that was draining that area. There's multiple instruments that we have in our robotic tool. This is what's called a vessel sealer. It's a bipolar coating between the jaws, so you can actually cause a coagulation of the vessels, but also able to transect through the tissues. You can see our vessel here. So we're make sure that we take the vessel as high as possible. That is what's called an oncologic resection, because we want to make sure that we harvest all the lymph nodes that are above it. And our vessel sealer can transect through that easily. So I'm going to move forward a little bit here. So I can show you some other parts of this. There's the mesentery. This is the small bowel that enters the colon, right? Because this is the right colon. So we resect a piece of that as well in order to get the margins that we need. And the robot also allows us to do something called fluoroscopy, which is called Endocyting fluoroscopy. So you can see that green color is basically an intravenous chemical that's injected at the time of surgery. And because we'll go wherever the blood goes, you can visually see which part of the bowel actually has perfusion or has blood flow. So that when you put two ends of the bowel back together, you know that those two ends have blood flow at the end. You don't have to guess by looking at it and thinking that, well, it looks pink, it looks viable, let's leave it. And obviously we have staples that we can use inside the belly. So it allows us to do the actual resection of the bowel. So we can move this forward a little bit. Now we have the two ends of the bowel. This is a colon, this is a small bowel, because the specimen is, the actual cancer is out of there. So now we have two closed plumbing basically. So we have to make sure that we put this back together. And you can see the articulation of the robot in there. It can suture basically the same way you would if your own hands were inside the belly. And I'll move it forward to this a little bit. So we obviously have to make some holes in order to do what we got to do. And you'll see now another staple go between the two ends of the bowel to create a common channel so that the two bowels are connected to each other, and whatever is passing through the small bowel will pass through the colon as well. And again, because we have great articulation, we can actually suture these holes and these openings with the robot pretty easily, actually. And at the end over here, I'll show you these pictures in a minute, so you don't have to wait for the video. But this is what the patient looks like, in the operating room. These metal, connections are where we attach the robotic arms, and we can place the instruments inside of the belly through it. This is the same patient at the end of the surgery. We can see how small these incisions are, and usually place glue on top of them. That's why it's shiny like that. And this is the same patient at 2 weeks afterwards. You see there's barely any incision, and these patients usually are out of the hospital within about a day to 2 days after the surgery. Here's another patient. This is a man. You can see the same type of incision in the operating room, and this was 1 week after surgery, so his glue was still attached here. And now this is a left colon resection or low anterior resection. As you recall, I mentioned that location matters, right? So this part of the colon is not quite as easily put together as the right colon because there's no small bowel here. So when you remove this part of the colon, the only thing that you have left afterwards is actually the rectum. So I'm going to move over here a little bit, but I just wanted to show you the cancer. So you can see as this, I missed it again. You can see as we kind of free up the attachments over here, the black dot again are the tattoos that the gastroenterologist placed. Maybe I missed it on the other side. Let's see. I'm just going to move forward here a little bit so you guys can see the important part of the dissection. That's, by the way, was the ureter. You can see it right there. If we have any urologist or anyone that works with the urinary system here knows how important that structure is. This is the uterus. So this is a woman. The GI guy went a little crazy with the tattoo, so there's a lot of ink everywhere. But you can see the mass up top here. You see it right there? So we get margins below the mass. The speed, by the way, is the same as the last procedures, about twice as fast as it was in real life. Again, we use similar instruments to dissect and get the margins and the vessels away from where we need them. So I'm going to just move forward here a little bit. There's a staple resecting the tissue, or the bowel really, below the mass. Now, on the left side of the colon, the vessel that matters is called the inferior mesenteric artery, or IMA. And this IMA is taken off, or is transected basically where it's coming off the aorta. So this thing that you see pulsating right here, that's the aorta. So you can imagine sometimes that can be a little exciting in the operating room where you're transecting this stuff and the vessels are not closed up adequately. And we take the rest of the mesentery. In this particular patient, the bowel actually was not perfused where I would expect it to be perfused. See how it's black? So I had to change my plan and resect up here in order to make sure that the blood supply to the colon was adequate. So I'm not going to bore you too much with this part, but basically we're making the proximal portion of the bowel ready for the connection. And you can see the anvil is passing through. If we have any surgeons on the call, I'm sure they've seen this part and are familiar with what we're seeing here. But basically, just to give you guys an idea, that's the rectal stump right here. That's the uterus. And we can place round staplers from the anal area basically inside and perform what's called a round anastomosis now, or a circular anastomosis. And there we go, we connect the two together. Again, like plumbing, but the only difference is that you can only work with what you got inside the belly. There's no extra plumbing you can get at Home Depot or Lowe's here. And you can see the staple closing, it will fire. And now what we do at the end is check this for making sure that the staple formation was airtight and also it's very well perfused. So the ICG fluoroscopy is first. You can see it's green all around. And there's the scope right now. So we inflate this with water, make sure that it's airtight. Just like when you had a hole in your bicycle tire, right? You put it under water, make sure that it's not bubbling. It's the same idea. You know, surgeons are simple people. We don't get too fancy here. And I think you're gonna see here what it looks like on the inside. There you go. So that's the proximal colon, and you can see the anastomosis right there. See the connection, the circular connection right there? And that tells us that it's good, well perfused, and it's got good blood flow on the anastomosis itself. And these are the incisions that I showed you earlier as well. So new advancement, we have the intracorporeal anastomosis, which uses transrectal extraction for usually benign disease and transvaginal extractions as well. And this was a video for a transrectal excision, but I'm just going to skip at the part where we extract the specimen because the rest of it is about the same. So you can see here, they'll do the same thing with the anvil, right? And there's a rectum that's open. Now, instead of closing the rectum, we actually use that to take the specimen out of the belly. Now look at this, how cool is that? Boom. Right? And then the rest is basically the same because, the steps are the same. Now we have the specimen out of the belly, and this patient would not need that incision at the base of the belly to extract the specimen. So now we just close the rectum up here, and then we do the same thing that we did before. There you go. Okay. All right. So let's move over to some information, some data. So why are we doing this? I mean, it's cool for us as surgeons to make advancement in surgery, but does it actually matter to the patients? So I'm talking about resections that I've done here in Bakersfield, California myself. So you're looking at April 2017 to January 2018. This is all surgeons, not just myself, doing MIS and open surgery. Now look at the length of stay that these patients were needed. It was about 44 and 43 in each group. This was obviously retrospective looking back because it wasn't a blinded study per se, but open surgery patients were in the hospital for an average of about 6.4 days. When they had an MIS procedure, lap or robotic, they were there for an average of 2.9 days. Now we have a robotic surgery center here at one of the hospitals here. It's called Mercy Hospital. This is looking at a year's worth of data. Different types of colon resection, left, rights, total colectomies, APRs, and look at their lengths of stay right here. See, pretty similar, right? So if you put all of them, average length of stay is still 2.7 days overall. And since we actually had a recent evaluation of some of the numbers that we had, and this is looking at basically 3 years worth of data, so 230, almost 240 colon resections, length of stay was still about 2.6 days. So it does have a significant impact on patients who are having these colorectal procedures, because the less time the patient is spending to recover from the surgery, the sooner they can go back to their lives, the sooner they can get started on chemotherapy, for example, if they need to get started on chemotherapy, the sooner they'll be able to get their next treatment done. The longer they need to recover from the surgery, the longer they need to be delayed to get their next treatment. So going back to colorectal cancer, details itself and kind of coming up full circle over here. What steps can you take to lower your risk of colorectal cancer and obviously of your patients as well? Get regular screening beginning at age 45, as mentioned many times already. But be aware of the fact that certain patients are not average risk, meaning that if they have family history of colorectal cancers or polyps, or if there's certain diseases in their medical history, their risk will not be average, which means that they may need to get screened a lot sooner. Eat plenty of fiber. I mentioned diet as an important factor in reducing the risk of colorectal cancer. The current recommendations are to take between 20 to 35 grams of fiber a day. And obviously a lot of this is found in fruits and vegetables and nuts and beans and things like that. Eat a low-fat diet. So for those who are, have heard from their patients or are interested in keto diet, that's not a recommended diet for reducing your risk of colorectal cancer. Eat foods that are high in folate. And for anyone who's a primary care physician or OBGYN here is familiar with prenatal vitamins and how important they are in pregnancy, making sure that the woman has adequate levels of folate as as the baby is growing. Well, the same factor is actually linked to colorectal cancer as well, because the development of mutations in those polyps will increase, or the risk, I should say, of development of mutations will increase if your folate levels are low. And you can find this in leafy green vegetables, which will also increase your fiber intake with it. Don't drink excessive alcohol and don't smoke. And if you smoke, try to stop. If you don't, obviously don't start. Exercise and physical inactivity. I showed that on the map of the United States. You can see it was basically one-to-one almost relationship to incidence and mortality rates of colorectal cancer. So exercising is important. Physical activity is important in general. So what should be, if somebody's asking you for details about what do you mean by physical activity, how much should I do, when should I do it? Well, the numbers that basically we're recommending and we're telling our patients is about 20 minutes a day, 3 to 4 days a week. And that does not mean that they have to go to the gym, 3 to 4 times a week and spend 20 minutes over there. Even simple walking, jogging, gardening, being active, going out on hikes, things like that. Anything that keeps them active will count as physical activity. So again, 20 minutes a day, 3 to 4 days a week. And here's another kind of graphic showing some of that idea. So diet, body mass index, which is weight, basically activity, and lifestyle. All right, and I think that's all I had for you guys today, and happy to take questions. I'm not sure if anybody used the chat function here.
Hey, Dr. Malellari, I have a question.
Hi.
First of all, thank you for that talk. That was very helpful. My question is, have you noticed any differences in post-operative anastomotic leaks with the robot versus open, just because we get so much less robotic training for these cases in residency than we do?
Yes. So to answer your question, yes, but there's a caveat to that. So when you go through general surgery training, most programs are not really exposing you to much robotic surgery. I didn't get any robotic training myself when I was a general surgeon. I got robotic training when I went to fellowship for my colorectal specialty. So the data there is that the risk of anastomotic leak, especially for left colon resections or low anterior resections, is about the same. But the reason for the caveat that I put over there is because you can do what's called Endocyting green fluoroscopy, which was that green color that you saw on the pictures. There's actually two big studies that were done with it. One is called Pillar 1 and Pillar 2 studies that showed that by using that technology to evaluate your anastomosis and the bowel that you put back together, you can actually significantly decrease the risk of anastomotic leak. Pillar 2 studies actually show that you can reduce that to 0. Again, these are studies that are done in academic centers with master surgeons and all that. So, but in real life, being able to evaluate the anastomosis, the perfusion part of this, yes, it does decrease the rate of anastomotic leak. And I can tell you from personal experience, I've had to change occasionally my anastomosis, either redo it or change where I was planning to do it because of what the fluoroscopy showed me at the time of surgery.
Thank you.
You're welcome.
Thank you, Dr. Malellari. That really was a great talk, very informative. One of my questions you already answered, and it was about the ICG. I don't see it used very often at NYU, but it seems like there's actual evidence that it does decrease the risk of anastomotic leaks.
Yep. So and I'm not surprised. It's not very common over there. The company that came up with this is actually out here on the West Coast. That's where they started. So most of the West Coast programs are much more aware, I guess, or familiar with it. I had never heard of ICG, like I said, or robot for that matter, until I went to my fellowship at UC Irvine here in California. But once you see it, it just makes sense, especially if you're a surgeon and you deal with bowel and surgery all the time. Once you see these videos, you're like, why are we not doing this? And that makes absolutely sure. Why should you guess whether your bowel is healthy and well perfused, especially when you're dealing with cancer surgery where you take these vessels as high as possible, right? So inferior mesenteric artery, taking it off completely from the aorta, that part of the bowel is only being perfused by your middle colics, right? So you hope and pray that those collaterals are good enough for your bowel to survive. But why guess? That's why ICG. And the thing is, it's not an expensive type of medication to use. The bottle that they use to inject ICG is like $20. The only part that's different is that you need the near infrared light in order to be able to see it. And the robot has that. They trademark it as Firefly, but basically it's a fluoroscopy. Now they do make some laparoscopic towers with near infrared cameras, basically trying to introduce this technology into laparoscopic surgery, both for bowel and things like gallbladders and upper GI surgeries. But I'm not, like I said, I'm not surprised you haven't been exposed much to it. I wasn't either on the East Coast. It has to do a lot more with where it is.
Yeah, we have access to it. I think just most of the attendings think that they can visualize bowel better than the ICG. Anyway, the other question was actually on the biology.
Yeah, the other thing I was going to say was, the surgeons that you work with and you get trained by, they've been doing this for 20, 30 years. We call them master surgeons for a reason, right? When you're out in the practice yourself, it's important to, to double check your work sometimes. And this thing is one of those objective findings that does not depend by who's watching it, right?
Yeah.
I'm sorry, go ahead. You had another question?
Yeah, just is the biology or is there data on the biology of colorectal cancer in the younger patients, or does it follow that same, adenoma carcinoma sequence?
Right. So it does follow the same adenoma to basically, like you said, carcinoma sequence from low grade, high grade dysplasia into carcinoma after, or invasive carcinoma afterwards. This is pretty early findings. I mean, we only seen this, I should say, we only proved this this increase over the past 20 years in data over the past 20 years. But the actual articles that are looking at this were published over the past 2 to 3 years. So there's a lot of really important research that's happening in that field to figure out why this is happening. There's theories out there about why this is happening, and smarter people than I have been talking about what they think is the reason for it. But there's no data to prove that there is a different biology on these cancers. What we do know is that they're obviously happening in younger patients when we don't expect them to develop this cancer. But more importantly, it's happening or I should say, they're being diagnosed at higher stages, meaning that the cancers have already advanced and gone to the lymph nodes or other organs by the time they get diagnosed. The leading theory right now about why this is happening is to do with dietary changes, meaning processed foods, meats, low fiber, high fat diets. But again, there's a lot of theories out there. We'll see what the data and the research is going to kind of come up with as conclusions on it.
Do you think the FIT testing will make its way to younger and younger patients just because it's non-invasive? And
right, it's a good question. FIT tests are pretty cheap, and a lot of them get covered by insurance anyway. That's it's something that will probably start becoming one of those things that, hey, even if you're 20, 30 years old, let's just do a FIT test, even if it's not every year. The only issue is the FIT test does have a pretty significantly high false negative and false positive rate. Fecal occult test, I think no one should be doing that. I put it on the slide because it's still there, but no one should be doing that. You have a steak the night before, that thing is going to be positive in the morning. I guarantee you that, because it's looking at hemoglobin. It doesn't look whether it's hemoglobin from, animal sources or human sources. So the FIT is much better at that because it's obviously specific to human hemoglobin. But the problem is that, 9 times out of 10, patients who are having bleeding per rectum or even a positive FIT test or fecal occult test, they're having, things like hemorrhoids or, anal rectal problems. They're not necessarily having cancer. The issue comes when their symptoms are being dismissed as just hemorrhoids, and they keep having bleeding and rectal problems like this until a colonoscopy is done, a year or 2 years later, and then they come back with a diagnosis of cancer. That is really the problem. But that is a good question. FIT tests may end up becoming a little bit more common, especially in younger patients.
Thank you.
Lawrence, I have a question.
Yes, hi.
Hi. So as an internist, primary care doctor, I kind of want to prevent everyone coming to you. So no offense. I mean, the presentation was amazing, and I think that the whole system is like pretty amazing, far advanced than what I ever seen. So if I have a couple of patients, I had a couple of patients recently asking me about the FIT test. Mm-hmm. And you pretty much answered the question because Sarah mentioned it. As a primary care, is it recommended to order it yearly, like between the colonoscopy, if it's like 10 years or within 3 years after finding a non-malignant polyp? What are the recommendations?
Right. So those recommendations about when to repeat the studies are if you're doing the same study. So for example, if you did a FIT test this year, then you should be doing a FIT test next year. If you do a colonoscopy, though, the reason why the colonoscopy, repeat is so wide, in terms of how much you wait, is because the colonoscopy is so much better than those tests, because you're actually visually seeing inside of the colon and finding out whether there's any abnormalities. The only problem with that test, and I don't know if you kind of get a sense when I showed you the video about the inside of the colon, is that there's a lot of folds in there. There's a lot of nooks and crannies where things can hide. The reason for the 10-year wait for colonoscopies that are normal is because it takes a long time for that polyp to start and then go to basically dysplasia or even malignancy. So the actual year that when this was studied, it was about 8 years for a normal mucosa to turn into a dysplasia or high-grade dysplasia. So they said, okay, if it takes 8 years to do that, let's do it at 10 years, so we'll still catch it before it turns into cancer. However, nowadays, most gastroenterologists and even surgeons will not wait 10 years for most people. Even if you have a normal colonoscopy, I'll probably repeat, especially as patients get older, I'll probably repeat in about 7 years. Because we're getting scared about all these younger patients that we're seeing in our office, and obviously our view is biased because we see a lot of them compared to what you see over there. But we see so many of these young patients that we don't want to miss it because we don't have enough information now. We don't know how to stratify these patients on what their risks are. So anybody that comes to see me for for hemorrhoids or bleeding or any other stuff, honestly, no matter what age they are, if what I see on their exam does not convince me that their bleeding reports are justified by it, everybody will get a colonoscopy.
Right.
But to answer your question about doing fit tests in between your colonoscopies, unless the colonoscopy was incomplete or the prep was poor, that's basically the physician's way of telling you that there might have been areas that they missed because they were covered with stool or it was difficult to examine. Then there's really no need to repeat the fit test in between the colonoscopies.
Okay.
I have a question. Unless Dr. Gashi has another additional question to follow.
No, I'm good.
That was great talk, Dr. Malellari. This is Arian Chayaktu.
Hi.
It is hard to have our Albanian moms and dads to see their PCP, let alone have them go get a colonoscopy. I mean, briefly put, we as a community do not believe in doctors. How do you tailor your conversation, especially with the Albanian patients, in regards to adhering to C-scope screening guidelines?
Right, so just to put things in perspective, I'm a colorectal surgeon myself, right? So I deal with colon cancer in and out. I see patients in their 30s and their 20s and their 40s with colon cancer. It took me about 2 years to get my dad to get a colonoscopy. And that's, talking to him every day and trying to get him to get it done. So that is a real problem, or the reluctance that our community, and we're not the only ones. I'm sure there's plenty of other communities that have the same problem about getting preventative care. That's really the key. Usually once you have somebody that has symptoms, they'll want whatever, they'll do whatever you tell them to do. But preventative care is very difficult. And there's no numbers and there's no data that's going to convince anyone. The only thing I would suggest is persistence. Basically keep bringing it up, keep reminding them that it's important to get this done. Usually a lot of patients will have a higher level of resistance to things like colonoscopies, because they have to clean their colon beforehand and it feels like it's a procedure and they don't want anybody sticking anything up their bottom, quote unquote. So in those cases, getting some, or at least performing some of those other, screening tests, like getting a Cologuard or getting a fit test done, at least it kind of buys you time, or it gives you an idea of what are you looking at. For patients who have family history though, you just gotta, scare them enough, I guess. I don't know how else to put it. You just gotta put things in perspective about how serious this really is. And when I tell patients, even here in my office, that, colon cancer is the second leading cause of cancer-related deaths in the United States, everybody's jaw goes to the floor. It's like, what do you mean? Because this is not a type of cancer that people are gonna go, on their barbecues and dinner events talk about, right? Even if you have a family member with this cancer, it becomes like something that they're ashamed about. No one wants to talk about this particular cancer. Another thing that I've noticed with with some of the my community, I guess, in Albania and here, is that a lot of people will know that they have family members with cancer or their diagnosis of cancer, but they don't know what kind of cancer they had. And that we're like, well, yeah, I had an uncle or an aunt with cancer. I was like, where was the cancer? No idea. And this matters because certain cancers can run in families and certain cancers do not run in families, right? So for when I mentioned earlier about the Lynch syndrome and HMPCC, this particular syndromes, you can really only diagnose them by getting an accurate family history. And there's certain cancers who are linked with colon cancer. Things like uterine cancer, ovarian cancer, cervical cancer can be linked to colorectal cancer as well. So knowing what type of cancer they had in their family, whether it's immediate siblings or other family members, is important to kind of gauge their risk of developing this cancer. But kind of going back to your question, it's a difficult job to get our community to embrace this. And I saw it myself. Like I said, it took me 2 years to get my dad to get a colonoscopy, and he was in his 60s because he wouldn't budge to get it done. But persistence is what's going to make a difference.
I have a question to follow up on this, if you can.
Yeah, no, of course. Go ahead.
First, thank you for being here with us tonight. I'm not a doctor, and I really enjoyed your presentation. It was so well done. My name is Roberta, and I am a founder and the chair of Albanian Fighting Cancer, a non-profit organization that is here in Boston. We created this organization a year ago. In our event organized before the pandemic, we had about 300 Albanians in an event that we talked about cancer, about preventing cancer. We invited Dr. Alia, Dr. Goldberg, and Dr. Clary from Brigham and Women Hospital to talk about colon cancer. And one of the fascinating, one of a kind was Dr. Chaushai that spoke to our event as well.
He was our past president.
Yeah, was a very memorable, I will never forget his speech for 25 minutes. He said something that really struck me. When he did a survey in Albania, more than 60% of patients were advanced in cancer and we couldn't do any surgery, he said. So what can we do as an organization to raise awareness in our community about colon cancer, which is treatable if you get it in the early stage? And we would like to invite you in one of our events in the future. And my second question is, so my first question is, what can we do more for our community? Because it's a stigma there. They don't want to talk. They don't want to say it. They are afraid, they are ashamed. My second question is, my sister was diagnosed with colon cancer at the age of 49, and I had the colonoscopy. They found about 7 polyps. Now, you said something that the family member should do the colonoscopy 10 years prior to when the family member was diagnosed. So that was very interesting to me. So my son, what age he can do the colonoscopy, and how often should I repeat the colonoscopy after my sister was diagnosed? And how often my son, which is 30 years old, or my sister's son should repeat and should start doing and then repeat after how many years?
Right. So I'm going to ask you a second question first. So as far as your case is concerned, I'm glad that you got your colonoscopy and they found those polyps and removed them before they had a chance to turn to cancer.
Yes.
The whole point about this, screening and colonoscopies is to find polyps, if they are there, not to find cancer. We don't want to diagnose cancer. We want to prevent it. Because colon cancer is a preventable disease as long as you can get screened. In your particular case, yes, usually our recommendations would be for if your sister was diagnosed for colorectal cancer at 49, then all her immediate siblings, brothers and sisters that she has would need to be screened at least at 40 or 39 to 40.
Yes, we all were screened after that.
Right, so that would be our initial recommendation. And again, that has to do with the fact that we want to catch polyps, if they are there, not cancer. We don't want to wait until cancer develops. That's why the 10-year, advanced screening is done. in your particular case or your son's case, or if they found 7 polyps, it's actually a pretty significant number of polyps.
Yeah.
Now, I don't know the pathology results of it, but if there was any kind of worrisome features on those polyps.
No, two were flat, and
Mhm.
the other were like normal, no precancer, but 7 of them is a lot.
Yeah, 7 is a lot.
4
So,
of them was in the A line
okay.
of the colon.
Right. So the 7, like I said, is a lot, but the details on the pathology matter, because if they were what's called adenomatous polyps, then they are precancerous, even though they don't have any changes. If they're polyps like hyperplastic features, those actually don't have a increased risk of developing polyps, because it's just a
What
little.
was the first name?
The first one is called adenomatous polyps. The second one is hyperplastic.
Okay.
I didn't put this in the slide because it goes into like very granular, detail. But basically, if there were adenomatous polyps, usually more than 2, you should repeat your colonoscopy within 3 years.
Okay.
7, like I said, is a lot. So if there was any one of them that had adenomatous polyps, I would make sure that you get another colonoscopy within 3 years.
Okay.
If there were no adenomatous features, then 5 years should be fine to wait. As far as your son is concerned, I'll probably make sure that he gets screened, probably 7 to 10 years before your colonoscopy was done. Because in the same thing, you want to make sure that if he gets a colonoscopy, he gets polyps found in there, not, changes into, cancerous cells or precancerous lesions. So not a full 10 years, because in your case, you didn't have a cancer when they did your colonoscopy, but, close to it.
Okay.
And to answer your first question, it's just going to take a lot of work from all of us, really. And I'm glad you guys are doing your events and meetings out there on the East Coast. I love Boston. I've been there many times.
Yeah, we love to have you one day.
Over there. We have our conferences over there every 3 years usually. But it's just going to take a lot of talking, basically, to remove the stigma and the shame, as you mentioned, about this. Patients who or Albanian people in general, when they hear that you have a cancer, they want you to have brain cancer, because that's a good cancer that you can talk about. If you have bowel cancer, colon cancer, rectal cancer, they're ashamed that they have it, as if, they did something that caused the cancer.
And they don't talk about family history. Nobody knows.
Nobody knows, exactly. And a lot of times, even if they know, they don't know the details enough to make it worthwhile or relevant.
Yeah. Thank you very much.
You're welcome. Thanks for joining us. Oh, and I'm happy to, join you guys if you have an event to give a talk.
We will, and thank you. Yeah, it's nice to have you here in Boston, or we can come and do another event in New York or California.
We can always go online and Zoom it out. So
yeah, that's another option now. Yeah, thank you.
Thank you.
I also have a question about the operative results amongst the different techniques. So I also come from an institution that predominantly does open and laparoscopic procedures, not so much robotic, but I'm assuming the pelvic views for the Da Vinci devices are advantageous. Have you noticed, say, any significant differences in terms of the distal margins or lymph nodes harvested?
Yeah. So as far as the actual oncologic surgery, if you're doing cancer surgery as a surgeon, those things like margins and the number of lymph nodes that you're harvesting and making sure that you're doing oncologic resection, that should not matter how you do it. So whether you do it open, laparoscopic, or robotic, those principles of surgery still apply. So you need to be able to know how to do those. Otherwise, don't do that surgery, because then you're doing a disservice to the patient. You may give them the wrong stage or the inappropriate stage as far as the treatment process, or the cancer can come back. So, you should be doing the same surgery no matter how you do it. But yes, the robotic surgery does allow, at least, in my hands, and, I'm not a master surgeon by any means, but I feel like I can give my patients a much better surgery robotically, especially done deep into the pelvis, and especially in those pelvises that are, narrow and bulky, like in male patients. Patients are very deep and narrow pelvises, which makes very difficult visualization or view of what's going on over there. And especially when you're dealing with cancer, you obviously have to go pretty wide margins. You have to do what's called the mesorectal resection of the rectum. So you want to protect those nerves that control sexual function, bladder function, and you want to avoid some of those complications that can happen. And I agree. I feel like robotic visualization is so much better than laparoscopic that it's not really in the same league. And I did a lot of open surgery when I was in my general surgery training. I did very little laparoscopic surgery. I did a lot of laparoscopic surgery during my fellowship, and I did some robotic, but even then I could see the difference. My shoulders and my elbows didn't hurt as much after robotic surgery. I could do several of them a day rather than do two and then need to lay down because your shoulder locks up after a while. The dexterity that you get with robotic surgery really is unbeatable. So in your case, if you're interested in doing bowel surgery or cancer surgery, and it's true and it's unfortunate, but the general surgery training does not give you adequate exposure to that. I would suggest either a fellowship training in minimally invasive or colorectal surgery or surgical oncology, or basically exposure to other surgeons who do a lot of those procedures during your initial practice. There's a lot of courses that you can follow for this. Obviously, if you join a practice that has other surgeons in it who do a lot of minimally invasive surgery, you can learn from your colleagues that way as well.
Great, thanks.
You're welcome, and good luck with your training. All right, any other questions there, guys? All right, I think we may be wrapping it up. Nora, did you have anything else you wanted to add? You're muted, we can't hear you.
You're muted.
Okay. Sorry, I'm at work, so I didn't want to make noise here.
No worries.
Thank you, Lawrence. That was great presentation, so informative, and we really appreciate you preparing everything for us. And thank you everyone for joining us. I encourage everyone to join the society, especially medical students. It's free, it's informative, educative. Everybody can participate, especially in these seminars. So we're here for you guys. Thank you again, Lawrence.
Thank you. And just one last thing, guys. The website for AMS is albametsociety.org, right? Maybe Jürgen can put that on the screen. There's going to be a link, obviously, to the talk over here, but also the links to join the society will be over there, and events that we're going to have in the future. So please join us.
Thank you very much.
Okay, great.
Thank you.
Thanks, everybody.
Thank you.
Thank you.